morning, Scott.
Hey Dan, how are you?
Fantastic.
Cool. I am looking forward to this discussion about our latest book.
Yeah, I probably said this before, but I just feel more affected by this particular book that we have today than I have with other things that we've read. I'm sure I've said that many times, but again,
Maybe privately, but I don't remember you saying that about that any of the books we've read publicly. We probably should let people know what book that is.
so for this time, we've read a book called Searching for
Searching for
Normal
Normal,
by Sami Timimi.
who is a psychiatrist who works in the UK. He's also agreed that once we record our review, that he'll listen to it and then we'll bring him on for an interview, much the same as we did with Will Dobud. And then also the
Eric
other book that
Kaplan.
Eric Kaplan. So you said you were more affected by this book, Dan. Can you say something about it?
Well, in one sense, it hones in on my career, which is as I'm not a psychiatrist, but I play one on TV. No, but I'm an addiction medicine doctor, and so I end up doing a fair amount of psychiatry and in the same sense practice kind of the way a psychiatrist would. Anyway, so it's in essence, it calls into question what have I been doing, and kind of what are we doing as a field, as mental health practitioners. It's very critical of what you would call the mental health industrial complex.
If we step back and we say, what is this book about? I would say that it's not just an anti-psychiatry or anti-mental health book. It's written in a much more persuasive, much more reader-friendly way. I think the audience could be mental health professionals, but it's also written in a way that people who are struggling in their lives could approach it. And it is challenging and kind of undoing and questioning using the methods of science, the way we organize the work we do, including diagnoses, treatment plans, and in particular, medications. He, in a methodical way, points out that much of the way we organize practice and talk with a degree of certainty about how to help people really has limited, if any, evidentiary basis. And it's hard to read this book written in the friendly tone that it is. This isn't a Peter Bregan kind of volume, and not come away as a mental health professional affected and ask yourself, what are we doing?
Right, and I think he quite frankly says throughout the book, we don't know what we're doing. We practice in what we consider a scientific way, but it's really different from modern Western medicine. You look at cardiology or certain surgical procedures. There is a very scientific basis for much of what happens there, but in our field, not so much.
So we speak in the language of science, but really what we have as a field is more scientism that we've talked about. We have all the trappings and language, and even some of the actions that look like scientifically informed healthcare, when in fact it's not that way. That as I read it, and he said several times in the volume, we literally don't know what we are doing. But he does it, or for me, he did it in a way that I didn't feel discouraged. I actually felt a little bit hopeful because these are difficult questions that our field needs to address and answer, and which Sami, I think, would argue are at the core of some of the problems that we're seeing, the so-called mental health crisis among our nation's youth. I think he would argue is in part, not completely, but due to the way we think about mental health and the way we're approaching it as a field.
And in one way, I felt hopeful because I feel like it is a kind of a vindication of the whole paradigm of feedback informed treatment, where you focus the client's wants, needs, goals at the top of the list, and you measure outcomes, you measure well-being as opposed to symptoms, and the idea that the outcomes really haven't improved in 50 years is sort of consistent with his philosophy that we're not measuring the right things, we're not focused on the right things.
And in fact, we may be trapping people in a way of thinking about their lives and their problems and how best to approach them with traditional psychiatric or psychological terminology. And he brings his laser-like focus and amassing of the research to bear on a number of popular topics of the day, including the rise of attention deficit disorder diagnoses, autism diagnoses. He ventures even into the fluidity of sexual identity and preferences in a way that suggests, again, that these concepts sound scientific, but they may actually be limiting us in terms of both how we approach and try to help people, and in terms of how people are educated to think about the best way to solve their problems.
Our system has medicalized diversity and difference. And I do think his ultimate conclusion is that this idea that there really is a normal is crazy. It's very limiting for the culture and the individuals who are searching for what normal is.
Yeah, and in fact, I can remember a conversation I had with Bruce Wampold on that very subject a couple of years ago, and he said, "You don't want a mental health professional telling you what normal is." And when I asked him why was that, he said, of course, first, that none of the diagnoses in the DSM, or few of them, are based on a deviation from a known normal. They're simply symptom clusters. But secondly, he said, part of the human condition is the diversity of ways in which people live their lives. So one of the other questions he addresses is, why is this happening? And you've hinted at a name that I think he uses, and it was the first time that I'd heard it, the mental health industrial complex, which in a way within our current systems of government, he believes has been exploiting perhaps the weaknesses and differences between people, if not intentionally, then indirectly.
So if I'm an addiction medicine doctor and I see some sort of behavior in a patient, I'm tempted to medicalize that aspect of what's going on.
What he's arguing is that we have to see people in context. The place where they live, the people that they're surrounded, the political context in which they're embedded.
Absolutely. And the way we have chosen to categorize the problems that people have, the mental health problems, is that we locate the issue within the person, between the ears, within their brain, within their neurochemistry, within their neural connections, rather than seeing it as a contextual problem, a problem that's in the culture, in the environment, in the home. And so it's very easy to, when you locate it within the body, within the brain, to medicalize it. You need to go to somebody to fix that problem.
Yeah. To ingest a chemical, or to be told that you need to exercise to increase serotonin levels, when Sami, I think, would argue, and many clinicians would argue as well, that maybe you're depressed because your economic situation is so bad because of the way the system operates around you, or because of what you've had to grow up with and contend with.
Yes. And I mean, I see that in my practice on a day-to-day basis. The people that I see for the most part who are in a residential program for addiction problems, I would say 80 to 90% are on multiple psychiatric medications.
He does chart the rise of the use of psychotropic or psychiatric drugs and how they convey a particular point of view about what causes problems. And I think Sami's trying to push out from that and say that it's not just between our ears, it's also in the society in which we live and happen to be embedded. Here's where the book takes a shift, and he hints at it throughout the various chapters, because if in fact it's about people in context, then we have to ask about the context and what could be changed about that. And in the last two chapters of the book, it takes a decidedly, you feel free to disagree with me about that, political turn. And he begins to offer ideas about what needs to be changed in society to help people address these problems in living that are caused by where they live rather than what's going on in their brain.
I believe that he's trying to understand this problem, if you will, the mental health industrial complex, and how it came about. You know, it's certainly harder to, you know, to analyze the veracity of the claims that he makes. I mean, I think he makes a pretty good argument for a lot of it.
Yeah.
Um,
Here's my challenge with it, and we've discussed this kind of thing before. Here's my challenge with it. And to me, I think he could simply have finished the book and said what he did say, which is that our current approaches have no empirical support, and left it there without offering what is, instead of a mental health approach, he offers a political solution. And my critique of this is that it's entirely predictable. Given his background as a psychiatrist and the leanings of the mental health professionals in general, you wouldn't be surprised by what he's offering.
well, it might be seen as by some as maybe polarizing, which sort of brings me to the kind of the sinking feeling that I was getting as I got through the book. I mean, I was eager at the beginning, and I was thinking, wow, I wish I'd written this because it makes so much sense. But I don't know if I should say this. I almost felt like quitting my jobs, you know, because I feel like I personally, I'm part of the mental health industrial complex, and I feel like I'd rather do something that was more productive in some ways.
Well, and in fact, maybe this is where we should leave things and bring this up to Sami, since he's caused us some existential angst that cannot possibly be blamed on where we live. It has to be blamed entirely on him.
That's right. It's right in here.
So let's stop here and interview Sami.
I look forward to it.
Good morning, Sami.
Hello, it's good afternoon from where I am.
That's right.
Nice to talk to you.
We are grateful for this opportunity. This is something that we have now done a few times, where we read an author's book and then they graciously agree to be interviewed after we do our review, clarify any of our misunderstandings or mistakes, or perhaps add nuance to what we have said about the book we've just read.
Yeah, sounds good to me. Thank you for inviting me.
Perfect. So, Sami, would you just take a moment and kind of introduce yourself, even though you do this, I think, very nicely in the book, to our viewers and our listeners? Who are you, and why this particular book at this time?
So I'm a child and adolescent psychiatrist and psychotherapist, and I've been practicing in psychiatry since 1989 and in child psychiatry since 1992, and as what we call a consultant child and adolescent psychiatrist, which is the equivalent of a team leader working in a team since 1997. So I've got a good few years of clinical experience behind me. I've worked in outpatients, I've worked in inpatients, in research, in academia. So I think I have a reasonable cross section of both practice and theory in this realm. So a lot of my ideas and the things I've written about have tended to be that combination of an understanding of the science, of the frameworks within which science is interpreted, but also that kind of nitty-gritty messiness of the reality of clinical practice, the reality of working in teams with other people, of trying to create services. I've done quite a bit of attempts, sometimes successful, sometimes not, at creating various types of projects within services. And then most recently, I'd written a number of more academic books and been co-author and co-editor in quite a few academic endeavors in the world of book publishing. But then most recently, I was lucky enough to be approached by a publisher who'd come across my work and wanted to publish something. And it just came at a very opportune moment for me to publish something in what in this country they call the trade book. In other words, a more commercial book, publishing for the lay audience, for the audience beyond the professional and academic circles that I've mainly been writing for. So that was resulted in the most recently published book called Searching for Normal, which I understand you've been reading.
Yes, we both have, and it really was profoundly impactful for both of us. Why this title to start off with, Searching for Normal? What are you tipping your hat towards? What are you trying to tell the reader with the title?
The idea for the title really comes from a sense that what we consider to be normal and outside the realms of normal, particularly when it comes to what we're thinking about in terms of mental health or behavioral differences, has been narrowing in all sorts of ways. But by the end of the book, so the title of the book reflects, if you like, an attempt to try and get underneath what is going on, that we seem to be categorizing so many more experiences and so many more behaviors as somehow standing outside of the realm what socially we would consider to be within the norms. But by the end of the book, which is also partly why it's searching, the idea of searching for normal, by the end of the book, I hope I've introduced the reader to the idea that the idea of normal itself is suspect. But this is something that we construct. This is something that isn't a given. There isn't a natural state that we can come to view as the normal state, and others being outside of that normal state. So one of the remarks that's close to the end of the epilogue in the book is references a T-shirt from a friend of mine who's a psychiatrist in New Zealand now. He was in this country. And that T-shirt is the Spanish translation of "Up close, no one is normal." I think that kind of captures an essence of the way we categorize people. And so a lot of the book is about that push to push people into categories that don't really exist beyond our subjective creation of these categories.
When you speak, I'm reminded of another one of my favorite books by McGilchrist, The Master and His Emissary. And it seems as though this push to categorize not only is affecting psychiatry, mental health discourse, but just in general, that we're trying to narrow, and that's the only way we can relate nowadays is to our categories rather than to people and raw experiences. But just a side thought, because it seems like there's a confluence of ideas and perspectives that are happening right now in the world that share a similar concern.
Yeah, I would agree with that, and this is partly why the book in the first half is really dealing with the science and ideology that has structured what we consider to be mental health and mental ill health, and looks behind, gives a few case examples, such as the growth of concepts like attention deficit hyperactivity disorder and autism. So it starts by looking at these and the growth of this way of thinking about what we consider to be mental health, and its tremendous expansion. But it's also why in the second half of the book, or kind of maybe the last third of the book, it starts to get into these wider societal questions. Because whilst that first half of the book relies a lot on concrete scientific evidence about the lack, or if you like, the lack of evidence about any biological or even substantiable psychological findings that can mark out different categories in a reliable and objective way. But in the second half, or that latter third of the book, I'm looking at these questions that are a lot more intangible, a lot more theoretical, and I guess there is a degree of conjecture. But it is an important bit because I'm trying to understand, why is something that is, when we have a picture that we've got expanding categories, expanding numbers of people falling into these created diagnostic categories, expanding number of people accessing treatments, and particularly the pharmacological, the amount of pharmacological treatment being given out, at the same time as the evidence showing that the outcomes from these approaches, at least at a population level, is far from something that you can point to that says that's making things better, making things progressive. In many cases, it's the opposite. Things seem to be getting worse the more we access those, this kind of what's referred to as the treatment prevention paradox. The more people are under treatment, the more there seems to be an association of people who are getting sicker. So why is this happening? So that gets into what you were just saying about this broader confluence, this broader sense that there is something broken, something not right. And I think a lot of people are scratching their heads trying to figure out what the hell is going on? Why does it feel like we're living in societies that are no longer functioning the way they should, or the way that we hoped that they would? You know, why have we got to the point where it seems that, at least for our younger generations, unlike perhaps we were part of the lucky generations, where we could look forward to potentially feeling that we're going to have a better and maybe more prosperous and more secure life than our parents, but the opposite is happening now. So it's interesting that you're pointing out to this confluence with other areas of reflection and speculation that are also asking these questions.
So I after reading your book, and you may have noticed it in the video, I'm I'm an addiction medicine doctor in California, and I work a couple places, but one of them is a residential program, and I I'm part of the mental health industrial complex, but you know, I my initial reaction was, gosh, I want to quit my job, and so I guess the question is, where do you find hope in our current systems of care? Or, how have you been able to influence the teams that you work with?
I think that I don't know if you can recall, but if you read the last chapter of the book, I wanted to try and distill an easy message to take away, because obviously we're dealing with, when we start looking at society and our place in society and how our services, our institutions arise from, and certain narratives get to dominate, it becomes quite complicated. But if there was a simple message to take away, it was to not to be afraid of emotions and emotional intensity. I mean, I titled that chapter Rehabilitating Emotions. That's probably not, I just couldn't think of a better title. It's almost like habilitating emotions. So a lot of the a lot of the messages that come across when we go down the route of categorizing, of calling our different, our more intense, sometimes frightening, often worrying, frustrating, angry making emotional experiences, when we go down the route of categorizing these as signs, as symptoms, as related to something that's broken, dysfunctional, dysregulated, choose your language, we set up a situation where we are sensitizing people to become in a battle potentially with a part of themselves which they consider to be not there, something that shouldn't be there, something that they have to try and suppress, get rid of, or manage in some sort of way. And that creates a certain meaning-making structure onto those experiences. In essence, they become a bit like meaningless torture rather than something that you can, by living through, by getting some perspectives on, by moving away from the idea that you are the ultimate cause of these difficult things happening, by introducing that different perspective and being able to get through and tolerate, we actually can deepen and enrich our psychological well-being. I'm one of these people who believe that you can't, or indeed shouldn't, teach resilience. I think that's something that you discover. And this is a role that I think the therapy culture can have a big part in playing. I gave several examples of different services, different approaches to services, different frameworks within which services can be conceived, which actually have done something along those lines, that don't talk about using a diagnostic framework or treatment plans in that same way. Services that talk about the first session as the engagement session rather than the assessment session. Services that move away from this fear-based risk assessment culture. And it includes services that I know you've been involved in trying to promote and build, and I've been involved in some of the work that people like you, Scott, have pioneered, which tries to put a relational perspective and a co-constructed perspective at the center of what we do. In that sense, there is something potentially, it's one of these very overused words, but I'm going to use it anyway. There is something potentially revolutionary about therapy services that want to move you out of this commodification of distress, this commercialization of distress, and that wants to help people feel more able to be empowered by their own knowledge. But some of the most impactful interventions I've been involved with have been with families who've been stuck in the system. As a consultant, I tend to get the people at the what are considered the more severe or more risky end. They're often people who've accessed several treatments before, or who have already tried various medications prescribed by other people, or who've been discharged from inpatient units. So it's kind of that severe end. And some of the most impactful times that I've experienced with people who I've worked with has been just being able to introduce and reintroduce and just keep gently working with people. And in the back of my mind, I think of them not as people with these disorders, these illnesses, but people struggling with what I call the ordinary and or understandable set of experiences, something to do with the way human beings are built. You know, when bad things happen, we feel bad, etc., etc. And often working your way through a mental health system and all the systems around that is in itself quite a upsetting, difficult experience. And if you keep that perspective in mind, that is the people that you will see. That is the things that you will notice. That is the stories that you can build on with people. And it's been nice to see. Just recently, I was at a child psychiatry conference, and somebody from the floor came and speak to me and said, did you know I used to be your patient? And she was now training as a child psychiatrist. I've had a few of those sorts of instances, and I remembered her, you know, working with her family. I get letters from people I've worked with many years who, when we came to discharge them, I encouraged them to see somebody else because we weren't getting anywhere. You'll know all about that, Scott, the whole thing of, you know, failing successfully. And then years later, they wanted to see me again. They'd turned 19, and they came back, and they said they did see somebody, but it didn't last very long. But some of the things that we talked about started to happen because I kept up the idea that that I'd seen a lot of strengths, a lot of capacity, a lot of resilience in this person, and that at some point the penny will start to drop, and at some point you will understand some of these things, and you don't know when people are going to look back. I used lots of metaphors, and some of the metaphors that I was using, it came back to him. Anyway, the reason he came back to me was because he was applying for a job, a training course that leads to a job, and he had to reveal his past mental health history, which was quite serious, and he needed a report now. And so I've had lots of experiences like that over the years, that even the most apparently hopeless seeming case, the sorts of case that get categorized as having treatment resistance or chronic mental health, they're not. They're not. So it's experiences like that, and working in teams. The other thing that I've discovered is that the opinions that people like myself, and I think you share many of my opinions, is in fact the majority opinion. What we consider to be mainstream is actually increasingly the minority opinion. It just so happens that they're the ones in power. So I see a huge potential amongst the I wanted to say army, but that sounds wrong and right in a strange way. The army of professionals working in mental health is that when you work in teams with people and they see that these ways of working make sense and you have these conversations, most people in the mental health arena are suspicious of these mainstream models and are looking for something else, and they will take it on. So I think there is a lot of reasons to be hopeful.
And you've sort of blown my mind here and reversed things in a way that also confirms something I think I believed but hadn't articulated so clearly. And that is that the minority is in fact in charge, but the vast majority of professionals, which fits my experience as I reflect on it, are wondering, thinking, are much less certain about the pronouncements that they might have to make, or the words that they might have to write on a treatment plan, or even to fill out a treatment plan. I'm tempted to ask, how did all that happen? How did it happen that the minority is in charge in this way? But I'm going to go in a slightly different direction, because not only have these words maybe been used by a minority of people to silence the majority who feel differently, but they've now escaped the therapy room. I was in a bookstore this weekend and looked at the magazine rack, which shrinks and shrinks given our increasingly digital world that we live in. But there were magazines for specific mental health diagnoses, ADHD Monthly. And it was kind of a shock to me. I actually took a picture of it because I'd never seen it before. It's not uncommon to be at a dinner party and hear people bandy about words of personality disorders used to describe members of their family and people at the party. And it's how did that happen even? And can we really make a difference when this language has escaped the therapy room in the way that it has? I guess is my question.
I resonate very strongly with what you've just said, and it was partly the reason why I was glad to have the opportunity to write something that's for the public. You know, if there was any way to try and affect this public discourse, even if it's a tiny bit here and there, it's worth doing. Because as much as we believe in and hope to work with and do work with in collaborative ways, in relational ways, people walk into your therapy room, into that encounter with a set of increasingly preconceived ideas about what's going on, having read magazines and articles and celebrities saying this or that other disorder, or YouTube influencers, and so on. And this is why I discuss what we call psychiatric diagnoses, they don't fit into a medical definition of diagnoses if you just look at it objectively and understand what a diagnostic category is meant to be. But what they do fit into is commercial brands. So I now refer to these categories as brands, and brands that have entered the marketplace at a particular time in our history, where, as we were talking about earlier, our economic systems seem to be in a decline. So that there's, all the issues to do with the crisis of living, how high housing costs, insecure jobs, etc., etc. But they're also experiencing a crisis of legitimacy. So we don't trust our media, and we don't trust that our politicians know how to solve the problems that we're experiencing. So this results in an increasing amount and state of distress, of insecurity, and feeling that there's nobody out there who's going to be able to deal with these subjective states. And because we exist in a marketized economy, this is the most recent, or one of the most recent ways in which that kind of dissatisfaction and alienation is being swept into the offer of these commodities. That's why I call them brands. And the successful brands tend to start growing in volume and diversifying in what they have to offer. So there are assessments, there are psychological treatments, pharmaceutical ones, books, courses, magazines, institutes, self-help programs, and so on and so forth. Once you get a market going, so it's almost like it begins to have a life of its own, because it's picking up a social anxiety and profiting from it. And one of the other reasons why it tends to develop a life of its own is that successful commodities in a marketized economy need to be able to convince you that if you stop consuming this or that product, your life will get worse. And they also need to convince you, or promise you that your life is going to get better if you consume this product. And good commodities, that feeling of life getting better doesn't last too long. So you need to keep consuming. And so I think this is related to the picture of why we see what we call these diagnostic brands and these therapy ideas and the concepts that, as you say, have come from the clinic space and are now out there. They've escaped into our general culture, has been booming. And I think it's up to people like us to do whatever we can to keep challenging that.
I want to make sure that listeners understand that placing this book in an anti-psychiatry area of the bookstore or in our mind would be a grave disservice to both the book and to the public. That's not what the book is. To me, what it is a very pro-science book and asking hard questions. And it, for me, dating all the way back to the early stages of the pandemic and prior to that, some of the people shouting the loudest about science were actually more interested in the results they believed in rather than the scientific method, which is messy, difficult, and often inconclusive.
Exactly.
What you do is very carefully and in a very readable way, both Dan and I agreed about this, present simply the science about some of the topics and diagnoses that are capturing popular attention, that have literally escaped the consulting room. And you do so in a way that doesn't provide, I think, simple answers. It simply says, we have to confront this. We have to confront the fact that in many instances, we literally don't know what we're doing, but that doesn't absolve us of the responsibility to do something, to figure out how to be helpful.
And the fact that we act as if we do know what we're doing, or we act as if we are practicing on the basis of some sort of science, which is really sort of scientistic rather than scientific.
Yeah. Yes, there's I label it scientism. Most of what is being called science, I label it as scientism. One of the ways, of course, that those people who are trying to question many aspects of mainstream practice is to actually apply that strategy of labeling. So it's easier to label someone anti-psychiatry, which I'm not. I'm certainly anti-bad psychiatry. I would hope most people are, but it's to label that as anti-psychiatry in order to avoid having a rational and reasoned discussion. And one of the things that I guess when I look at the science, I'm trying to address two things. Firstly is, what does the actual science tell us in terms of, do we have, are we applying scientific principles to an understanding of the nature of the categories that we are using? Where is the science to support that? And are we applying scientific principles to an understanding of the impact of the treatments that we are using? But a related question is understanding that science itself involves a certain type of methodology, but it is not the only way through which to develop knowledge. I sometimes use the analogy of eating an apple. So if you have an apple, there are many things that you can say about that apple, which is impacted by empirical knowledge. So you can understand something about the constituents, about the types of ways of growing an apple, of increasing the yields, of transporting, of preserving. All of this empirical knowledge will be of great help to farmers, to the shopkeepers, and so on and so forth. But when it comes to eating the apple, none of that knowledge is going to help me understand what it's going to taste like. So that's a kind of a different type of, that's in the realm of a different type of knowledge, a more experiential knowledge. It also won't help me understand what that apple tastes like to either you, Scott, or you, Dan. I might have some empathy, but that empathy will be based on my experience. But you might not like the same things that I like, the same tastes that I like. I might get a better understanding about that by talking to you and getting your opinion. You might tell me the truth. You might be trying to be polite, you know. So we're into a different area of knowledge. So that is important to understand too, because when we get into that area of knowledge, like you were saying, Dan, it's messy. It's not something that is resolvable by a scientific formula.
In this review of the science, one of the questions I had as I finished the book was, would it have been sufficient, Sami, to simply end by reviewing the science and saying, we really don't know what we're doing? as opposed to the way it did end, which for me started to take maybe a broader social, contextual, even a political, I might say, stance. What was your thinking about that?
I think my editors wanted me to do what you wanted to do, or what you suggested just now. In some ways, that has already been done. Perhaps I've presented it a bit differently, but I'm certainly not the first critic of the science, and not the first critic to present the various limitations. But the reason why I wanted to go a bit further and try and understand what might be contributing the undercurrents contributing to such a irrational system, and for concepts that are modern versions of astrology, as far as I can see, to have spread so far and wide and still be called scientific, because that is almost like science as a system of faith rather than science as a system of empirical study. So I wanted to get into what I understood was going to be speculative to a degree, enter into that rather tricky terrain of what might be the drivers, just like as I was talking about just now, that it led me to the conclusion that what we call psychiatric diagnoses are actually commercial brands. So why are commercial brands taking hold so much? What might it have to do with our sense of society as a whole and what's happening in society as a whole, particularly in those societies where these narratives about mental health have emerged, which is our kind of Western, European and North American in particular cultures and political systems. And I realize that that's going to put some people off who will agree with a lot of the books. And to me, that was also related to, I'm going to put people off from the left and put people off from the right, because I see what's happened in what I call the growth of the mental health industrial complex is that as it escaped the clinic and went into broader culture, it started to merge with a certain turn that left-wing politics took, where it lost interest or lost centrality of a socioeconomic or class-based analysis, and went into identity politics. So the culture wars became the ground upon which left and right fought, and the basics of the economic system was sort of no longer up for discussion. And I wanted to try and understand how could something like attention deficit hyperactivity disorder now become a valorized identity? How is it that certain things that people would feel, particularly young people, would not want to associate themselves with, how is it that they're coming to see this as something important about themselves? Where does all of those drivers come from? And because I was seeing this connection between the growth of this mental health industrial complex alongside the growth of identity politics, I felt there was probably some relationship that needed to be explored and understood. Yeah.
So just so I'm clear, that the two sides of this were not just left and right, but the movement away from analysis of the impact of class and economics on people's sense of their quality of life, and devolved or changed, evolved into the identity politics where left and right have now been fighting for the last 40 to 50 years.
Yeah. So it was about who gets the right to enter into these higher levels, into the elite status, into the high paying jobs, into becoming CEOs. So it became a lot more about visibility.
You know, Dan and I were talking before the recording started about what are very large open air drug markets in the United States. And as you know, for me, I worked in with a homeless population for much of my career, and seeing what's happening now in some of these drug spaces. And the clients we were seeing at the time were, we thought, challenged in many ways, poorly resourced, cognitive limitations at times, the types of drugs that were being used. But seeing what people are dealing with and how they're struggling nowadays, the problem seems so enormous that I think, Dan, you joked that, yeah, should we set up a schedule to challenge their dysfunctional thoughts when they're hunched and bent over and largely unconscious for hours a day? And what do we do about this? How do we intervene?
But you've just given a great example of if you shift things away from the political space where it is up to our governments and up to the institutions that have their hands on the levers of power to do something in that social economic space, if we shift it to the idea that these are people who are like that because of lack of willpower or a disorder between the ears, or something internal, you're letting those systems off the hook.
Suggesting that, you mental health professionals, you're the ones that need to fix this problem.
Yeah. Yes. And that's something I think we need to be aware of. And we can do whatever we can, but we also need to be aware of the limitations of what we can do in terms of these structural socio-economic problems. It is not in our gift.
And so what should the therapist do given that reality?
There is very little that they can do as an individual. So a part of this is about recognizing that change at a societal level comes from a social grouping working together, and the larger that social grouping, in order to bring pressure to bear. So in some ways we can act as advocates. There is something that we can't escape, that we live in politicized spaces, and particularly what you've just described seems a very apt example of what happens when socioeconomic realities get shifted out of the spotlight. It's not going to be a satisfactory answer, but with individuals, you're going to do what you can. And one of the things that I've had a lot of trainees from a lot of different backgrounds over the years, including psychiatry trainees. One of the first things I have a chat with people about is be careful not to burden your patients with your own need for them to recover. Doctors have a particular problem with that. There is a bit of a, because if you need your patient, if you pass that burden on, that you need your patients to get better in order for you to feel that you're being effective, and they don't get better, The temptation is, one, to blame them. They're not cooperating. They're not working hard enough. They're too sick. They're treatment resistant. And two, to try more aggressive interventions. So I think we really need not to burden our patients with our own, if you like, narcissistic need for people to get better. And that's something about understanding our own limitations. In the same way, when patients recover, it's not due to our amazing interpretation or, you know, our great gifts therapeutically or the wonderful drug. Even when the patient comes back and says, oh yeah, this prescription has helped me feel better, I ask questions like, well, what did it enable you to connect with about yourself? Because remember, a drug can't think. It doesn't make decisions. What have you discovered or rediscovered about yourself? So always remember, it is the people that you're working with. When they make progress, it is them. When they're not making progress, don't take it upon yourself to defend your own feelings of therapeutic prowess by blaming them or attempting even harder interventions. We have to understand our limitations.
I have found myself in treatment team meetings, however, when patients or when provider, you know, clinicians, whatever I hate the term provider, but that's just what gets used. When they say something like, well, you know, this person has been resistant to our programming, you know, I'll say things like, you know, we're responsible for the engagement. We're responsible for working on the engagement or trying to improve the engagement. I'm just wondering what you think about that.
I think that sounds perfectly reasonable. You're taking responsibility for the bit that you can do rather than when you're saying this person isn't engaging, well, that might be the case. But if you're taking a relational perspective, which I'm pretty sure that that's what you do, the only bit is what I'm saying. The only bit you can take responsibility for is your bit of that relationship. You do not have the power to get into somebody's mind and control. As much as we might want to find a way to get them to do what we think they should do, this is about respecting the inevitable autonomy of people and not seeing that as a sign of failure, or conversely, when they are successful, not recognizing the patient's autonomy in achieving that success. But working on that side, the side that we're involved with, is precisely what we should be doing. I've certainly had situations, and I know you'll know well about the power of repairing a therapeutic rupture. I've certainly had situations where the patients have fallen out with me, families I've been seeing, and the session has not gone well. So I pick up the phone. I give it usually a couple of days. I want things to be a bit, a few days. I pick up the phone and I apologize. I say it went wrong. I apologize for, I didn't understand this, or I found myself thinking this, and now I'm wondering why I did that. I try and be honest, and people come back and they engage. So that's the side that you can take responsibility for.
You probably recall that one of our findings from looking at therapists who had the best outcomes was, in fact, that those therapists tended to have more therapist-initiated unplanned contact between visits, both when they felt the need to repair the relationship and also because they were just plainly thinking about the person and wanted to catch up and say hello. Yeah. Sami, I'm sure Dan will agree with me that as I was listening, I was noticing what was happening in my own body as we were talking. And I felt calmer and calmer as you spoke. Your patience and your humility, it just oozes out of the conversation. And I'm really grateful that you've written this book, that you've shared your wisdom, and I hope people, and we will certainly promote the book and the work that you're doing.
And I mean,
Thank-
I felt the exact same way, and I almost feel like telling you I actually really like to have a session with you.
If
Oh,
there
thank you.
if there is someone who would like to reach out or learn more, what would be the best way to do that, Sami?
Well, first of all, thank you for that feedback. Much appreciated. I have a website. I'm that's samitimimi.co.uk.
Perfect. Perfect.
Oh, thank you so much. So nice to talk to you both.
Thanks, Sami.
Thank you.